All right, here we go. Hello, everyone, and thank you for watching this program on diagnosis pointing and the 1500 form. There's no audio taping or videotaping allowed, and any unauthorized reproduction, dispensing, or forwarding of this target coding presentation is illegal. The information contained in this presentation is for educational purposes. It's not intended to be legal advice. Target coding does not engage in providing legal services. We are not a law firm. CPT is a registered trademark of the AMA. Every attempt has been made certain to make certain that the information in this presentation is 100% accurate. However, it is not guaranteed. Let me tell you a little bit about myself for those of you that do not know me before we get started. My name is Dr. Marty Kotler. I am a chiropractor. I'm also certified in CPT coding. I am a certified professional compliance officer. I've written many books and training manuals on chiropractic billing, coding, and documentation. I'm a contributing author to Chiropractic Economics, Dynamic Chiropractic, and many state association newsletters across the country. I'm a featured speaker for the Coding Institute, Parker Seminars, and Foot Levelers. I've done presentations to over 3,500 chiropractors and their staff members over the last 10 years. And plus, I'm a guest speaker at many state association conventions. So now let's talk a little bit about the 1500 form. The 1500 form, although many people think it's a federal government type form and it's regulated by the federal government, it's not. It's maintained by a company called National Uniform Claim Committee, NUCC. The website is nucc.org, and some of the information that I'm going to be sharing with you is directly from this company. A lot of the information on the 1500 form comes directly from this organization. Now, this 1500 form, many people still call it the HCFA form, the 1500 form, the CMS form. You know, there's all different terms for it. I call it the 1500 form. It was updated back in April of 2014, so there were some changes that occurred. Those of you that are in practice more than 3 or 4 years, you remember the older form didn't have the proper amount of space and information in order for us to tell the complete story, and then came along ICD-10, and then this form had to be revised and updated. So this is what the form looks like. There are 33 boxes. So let's go through each box. The box 1 is where you're going to check what type of health plan the patient has. Is pretty straightforward. The top of the form, the first 13 boxes, you know, that's where all the patient information goes in. It's pretty straightforward. So 1A is the patient's insured ID number. You can get that right off the patient's card typically. And then the patient's name in box 2, birth date in 3, insured name in 4, patient address in 5, patient relationship to insured is 6, insured address is 7. 8 used to have information back on the old form, but 8 is just reserved for NUCC use. 9 is the other insured name. 10 is patient's condition related to, and this is a little tricky here. Box 10, if you are treating a personal injury patient and now the benefits get exhausted and now you want to bill the patient's regular health insurance, you still need to check that the condition is related to the accident, so you would check yes to 10B. And then we have box 11. So box 11 I want to focus on a little bit deeper now. Box 11, specifically 11D. 11D, it says, is there another health plan? So you have to check yes or no. Now this is very important in many situations. You know, many insurance companies, they are always looking for a reason not to pay. You've probably heard that. Or if they're not the responsible party, then why should they pay? So this is where you're disclosing, is there another health plan? Very important on Medicare claims. So if no, that's fine. If yes, you have to go back to box 9 and complete 9, 9A, and 9D. I've seen some claims get denied because this box was not completed. Okay, now let's move over to box 12. again here, this is more administration information. Staff members need to make sure that these two boxes are either signed by the patient or you have your own separate forms. So, for example, box 12, it says patient's or authorized person's signature. I authorize the release of information in order to process this claim. So, many software programs will automatically enter and populate signature on file. So my question to you is, do you really have a signature on file? You need to have a signature on file. So you either have to get the patient to actually sign this 1500 form, and one of them can be used as your master form. You put that in the patient's file or scan it into your system and shred the paper form. I know more and more people want to go paperless, so there's always the opportunity to scan any paper forms into your system. You can shred the paper. We try here at Target Coding to have as little paper as possible. We're trying to get away from paper. We're doing a really good job. We've been working on it for a couple of years now. So in your practice, you're probably better off having as little paper as possible. So either the patient has to sign an original 1500 form, or you may have to have a separate form. Maybe it's in your intake paperwork where the patients are signing off on the release of information in order to process the claim. Now also box 13, which is the last box in the top portion of the form, it says insured or authorized person's signature, I authorize payment of medical benefits. So this is a direction to a health plan to send payment directly to their provider. And many software programs will automatically populate signature on file. Well, do you really have one? So my recommendation is do a little research. If you don't know for sure, check into it. This is one of these spot checks where you may have just been automatically just populating signature on file and you don't have one. Well, check into it, see where it is. Doctors listening to this, ask your staff, do we really have one of these signatures on file? If you can't find it, then start figuring out how to fix it. Now, if you want to have just a separate standalone form, here's what it would look like. It's basically boxes 12 and 13 and a little bit of reimbursement policy on this form. So you could, if you can't find the signature on file or any type of signature by the patient for the release of information and authorization of assignment, then create a separate form, pretty straightforward, like the one you see on your screen. Okay, so that's the top of the form. Now we're going to start digging into the bottom portion of the form. So the top of the form is boxes 1 through 13. The bottom of the form are boxes 14 through 33. So let's start off with box 14. This is date of current illness, injury, or pregnancy. So you're going to enter the 6-digit or 8-digit date of the first date of the present illness. Okay, so this is a little confusing for some providers. So if Mr. Jones comes into the practice on March 15th, I recommend you put March 15th in box 14. Now, some offices will say, well, isn't it the date of the injury? Well, if it's a workers' comp or auto accident, and the injury was, June 15th of 2009, well, then you want to put June 15th, 2009 in box 14. When it's workers' comp or auto accident personal injury, you put that in the box and it never changes. Now, a non-work comp, non-auto accident, just a regular commercial health insurance situation, Mr. Jones walks in on March 15th. I recommend you put March 15th. Now, if you ask, Mr. Jones, when did your problem start? And Mr. Jones says, well, it started, back in 1999. I remember the day exactly. It was, July, 14th of 1999 is when I fell and I hurt myself. I fell off a ladder. I don't recommend you put July 14th, 1999 in box 14. So Mr. Jones walks in on March 15th. Put March 15th in there. Now, if you have an old date in there, there are some Medicare audits going on right now throughout the country. And some providers, the date of service is March 15th, but the date in box 14 is a couple of years prior to March 15th. So it's a situation where Medicare could say, why is this patient coming in for 2 years? Or we want to see the notes from the date in box 14 through the date of service, which could be a few years. So my recommendation is, whenever there's a change in condition where you have to update the diagnosis, update the treatment plan, then you put that date in. So Mr. Jones comes in on March 15th, he gets 10, 12 treatments, and then he comes in on April 20th with a new problem, an exacerbation, a change in condition, then put April 20th in box 14. So you want to try and keep the date in box 14 as close to the date of service as possible to paint the picture that this is active treatment, the patient is in a present episode. See, this 1500 form, it's a form. It has 33 boxes, but what you need to do is paint a story, paint a picture that's as comprehensive as possible in these 33 boxes. And for some offices it's easy, for some it's a challenge. So I'm trying to show you in this presentation how to paint the best picture possible so your claim gets processed properly and quickly and efficiently. So there's also something in box 14 called a qualifier. You have two choices, 431 onset of current illness or 484, which is the LMP that really doesn't apply to chiropractic. Now let's go to box 15. Box 15 says other date. Now, if you're leaving box 15 blank and your claims are getting processed properly, don't enter anything in there now based on this presentation. You know, you want to go with what works. So we don't want to reinvent the wheel here. We don't want to fix something that's not broken, right? All the cliches. So if you're leaving box 15 blank and your claims are getting processed properly, then don't mess with it now. But some plans want box 15 completed. So here's another situation where you have to enter the date of the patient's condition or treatment, enter the 6-digit or 8-digit, and then there's an applicable qualifier. So let's say Mr. Jones was in an automobile accident on October 15th. Well, you're going to put October 15th in box 14, and then the date of the initial treatment in your office was a month later. So the accident was on October 15th, but Mr. Jones didn't come see you until November 15th. So with the qualifier 454, that's how you're telling the story. Date of injury versus date of initial treatment. Okay, let's move along. Box 16 is date patient unable to work, so you could put that in, and then we get to 17 and 17B. Let's concentrate on this. This is name of a referring provider or other source. You're going to enter the name followed by the credentials. So for example, you were referred a patient by Dr. Michael Smith, medical doctor. Let's say you have a nice relationship with an orthopedic surgeon, and after the surgery or before the surgery, the patient is recommended by Dr. Michael Smith, medical doctor, to come see you for your opinion, your evaluation. And you're going to be billing possibly for a consultation code. Many plans want to see the name of the referring provider. There are some practices that, well, I work with many integrated multi-specialty practices where you have the supervising medical doctor and then you have a nurse practitioner seeing the patient. Many health plans want the supervising collaborative MD's name in 17, even though they're not referring the patient. Some Medicare plans want the name of the chiropractor in 17, even though the chiropractor didn't get a referral. The patient wasn't referred by another provider. The patient just walked in off the street. Some Medicare plans want the chiropractor's name in 17. And then you want the provider's name in 17, and then that provider's NPI number in 17B. And these are the things where, you know, especially I feel bad for new staff members when they're in charge of billing and they go through a whole training session and they're trained how to complete these forms and how to do billing, and they send it in and it comes back denied. And they thought the claim looked perfect when it went out, and it comes back denied. And now the staff member is frustrated, and they just can't figure out why it was denied. The EOB comes back, and it's very vague, and it doesn't give a specific reason why. That could be frustrating. It could be as simple as you needed to put the name of the referring provider in 17. And that brings up another point. There are many times where I've worked with providers where we fill out the form perfectly. Every box is filled out exactly the way the health plan wants it. The claim goes in, comes back rejected. What? What happened? The health plan has a problem in their system. They have a software glitch. They're not processing it properly. It wasn't your fault. So that could be frustrating. But hopefully most of your claims are going in and getting processed properly. And this will just give you a couple of more helpful tips and hints to make them work even more efficiently. So you could fill out the form perfectly. It goes in and gets denied. Well, maybe your group NPI and individual NPI numbers were transposed in the system, and that's why it got denied. So many reasons why it can get denied. All right, let's move on to box 18, dates of hospitalization. 19, yeah, 19 is one of these, additional information, anything you want to share. Some plans want to see the date of the x-rays or the exam placed in box 19. 20, outside lab, yes or no. 21, okay, here we go. We're going to be spending a lot of time on box 21. Box 21 has up to 12 diagnosis codes can be entered. The old claim there was only 4, and it was labeled 1 through 4. And doctors, even to this day, and staff members will tell me it happens all the time. Well, Marty, we could only put 4 diagnosis codes on the claim. I still hear that, even though the form was updated, 3 years ago. That's old news. It's not only 4. Now, you may only want to report 4, even though you may have 5, 6, or 7 diagnosis codes in your notes, but you may only want to report 4. Some health plans, they only want to see 1 diagnosis in position A. So there's up to 12 diagnosis codes. There's an ICD indicator. That should be the number 0 for ICD-10. You want to report codes to the highest degree of specificity. So we're going to get back to box 21 when we go over diagnosis pointing. Okay, 22, resubmission code, typically left blank. 23, prior authorization, typically left blank. 24A, date of service. 24B, place of service. So if you treat patients in your office, the place of service is the number 11. If you do a home visit, it's the number 12. There are numerous place of service locator codes. Everything remains the same. Here's another pretty common question I get. Marty, I'm going to a patient's home to do a home visit. I'm going to bring my chiropractic table and I'm going to adjust the patient in their home. Can I charge more? What do I do differently? Are different codes, different CPT codes, different diagnosis codes? Well, I could tell you pretty much across the board, the claim would remain the same for everything as if it was done in the office except place of service. Would have to be the number 12 if you're doing a home visit. I have some clients where they go to the patient's place of employment. They may go to the patient's work site where there might be 5 or 10 employees that come and see you on their lunch break. You should put the number 18 in 24B. Quite a few doctors I work with, they do chiropractic care in nursing homes and assisted living facilities. So that's a different number. Okay, now 24C is blank. 24D is where you're going to put your CPT codes, your HCPCS codes, and your modifiers. There's room for up to 4 modifiers per CPT code. 24E is the diagnosis pointer. That's where letters will go in to 24E to point to the appropriate diagnosis in box 21. And then we have 24F, charges. G for units. H, leave blank. I is typically left blank. J is the NPI number of the rendering provider. 25 is your tax ID number or your Social Security number. 26, patient's account number. 27, accept assignment. Now here, this is important, 27. If you are a cash practice where patients are paying you at the time of service, there aren't too many doctors like this, but I'll share it with you. There are a few doctors that have said, Dr. Kotler, I do not accept Medicare patients. I do not accept personal injury. I do not accept workers' comp. I only accept regular insurance patients, and I do not accept assignment. I am a cash practice. I am out of network with every plan. If the patient happens to have insurance, I want the check to go to the patient. I do not want the insurance checks. Make sure you check no in box 27. Now the checks might still come to you, so then you'll, my recommendation is you deposit the check and then write the patient a reimbursement check, so there's a wash for accounting purposes. Now if you are in network, you're participating with certain plans, you're automatically going to be set up as accepting assignment. 28, total charge. 29, amount paid. 30, leave blank. 31 is typically the provider that actually saw the patient. 32 is the service facility. 33A will be the billing provider individual NPI number, or if you're set up as a group, that's where 33A will be the group NPI number. Now, a little bit about the, so that's it for all 33 boxes. There's information, I don't know how many of you have ever turned over and looked at the back of the form. There's a lot of information on there on the back of the form. I think I was in practice about 5 or 6 years before I realized there was anything on the back of the form. So I turned it over, start reading it, and there's some basic, very important information here. It says any person who knowingly files a statement of a claim containing misrepresentation or false information could be subject to criminal penalties. It also says, for this claim, whether submitted by me or on my behalf by my billing company, complies with all the rules and regulations. Next, the services on this form were medically necessary and personally furnished by me or incident to. So again, that goes back to a little bit about cash practices. Providers that are seeing patients, cash practice, the patient is asking for a 1500 form or you're submitting it, and now this is going in as a medically necessary service. Even though you're a cash practice, you're attesting to the fact that the care was medically necessary, so you're held to that standard. More information about Incident to services on the back of the form. If you have any comments or questions about possibly improving the form, I did send some information here on improving the form. You could send it to CMS in Baltimore. Don't send claims to this address. This is where you can submit your questions or suggestions. Don't mail claims to this address. All right, now let's talk about diagnosis pointing. So here's a claim on Mary Patient. So Mary Patient comes in, and this is a group health plan. This is a sample claim going out with chiropractic manipulation or adjustment, 98940. We're also doing manual therapy, that's 97140, and a separate anatomic site. We're also doing unattended electrical stim. You can see here on this sample, it's 97014, or some plans require the HCPCS code of G0283, and then we have therapeutic exercises 97110. So we have 4 services. So 98940, you'll see in box 24E has the letters A and B. So I'm pointing the chiropractic adjustment to diagnosis codes A and B. What's in A? M51.16. That's lumbar radiculopathy. And in B, lumbar spasm. So I'm pointing to 2 lumbar codes, that's where I did the chiropractic adjustment. Next line item, 97140 with the 59 modifier. What does 24E say? C and D. So C and D, that's cervical radiculopathy and myofascial pain. So I am doing the manual therapy on the cervical region, separate than the lumbar region. That's why I have the 59 modifier. Next, I'm going to do electrical muscle stim, unattended electrical muscle stim to where? What does it say? E and F. E and F, that's thoracic disc degeneration, M51.34, and thoracic pain. So the electrical stim, I'm just doing on the thoracic area. Now, I'm just showing you this particular situation. Wait, before I finish, then the next is 97110. That's A and B. Where am I doing? That's therapeutic exercises. Where am I doing the therapeutic exercises? A and B? On the lumbar region. So let me now continue what I was about to say. So this is a situation for educational purposes. This might not be practical in your office. So just understand, I'm showing you this for educational purposes to show you and explain how you can, if you really wanted to get very, very specific, show for each service you're providing what body part and what diagnosis is attached to the CPT code. This is called CPT ICD-10 linking or pairing. Very important that you pair your codes properly, like you link, or you pair red meat with red wine and fish with white wine. You should be pairing your procedure codes, your CPT codes, with your diagnosis codes. So just to recap this claim, adjusted lumbar region, manual therapy, cervical region. STIM was on the thoracic region. And then the therapeutic exercises were in the lower back region. Let's take another example. Here's a Medicare example. So Mary patient comes in. We see 98941 with the AT modifier. Where's that pointing? A, B, C, D. Okay, so A is cervical subluxation. B is also cervical disc condition. C is lumbar subluxation. D, M54.41, that's sciatica with low back pain on the right side. So that's where I'm doing my chiropractic adjustments. I'm also doing my adjustments on M9902, which is thoracic subluxation, and M48.04 is thoracic stenosis. So I'm doing my chiropractic adjustment on 3 regions. There are the 3 subluxations and the 3 secondaries. What else did I do? I did mechanical traction, 97012. Again, this is a Medicare claim, so I'm using the GY modifier. We're not going to get into modifiers on this webinar. So the GY basically means it's a statutorily excluded service. Medicare will not pay. That's a good modifier to use on traction. And where am I doing the traction? A and B, only on the cervical region. I'll give you one more example. How about a personal injury patient comes in? And now we're going to do a chiropractic adjustment, 3 regions. We're also going to do therapeutic activities and massage. So the chiropractic adjustment is going to the lumbar, the SI joint. So M51.27 is lumbar disc. S33.6 is SI joint sprain. We're going to get into that in a few minutes, the SI joint sprain. And then in C is thoracic pain, and then there's back spasm. And S43.422, that's rotator cuff sprain. And M25.512 is shoulder pain on the left side. So the adjustment is on the lumbar, the sacrum, and the thoracic. There's my 98941. I'm also doing therapeutic activities to the lumbar, the sacrum, and the thoracic region. Where am I doing the massage? 97124. It's on the shoulder, E and F. E is rotator cuff. F is shoulder pain. So I'm showing the health plan, or anybody that's looking at my claim, I'm trying to tell a story. Adjustment on the spine, therapeutic exercises on the spine, doing the massage on the shoulder. Now I mentioned S33.6, sacroiliac joint sprain. A, initial encounter, D, subsequent, S, sequela. So now if you are going to diagnose a patient with a sacroiliac joint problem, whether it's a sprain, sacroiliitis, or sacroiliac joint subluxation, there are a few findings that you should have in your notes. So now ICD-10 scrutiny has gone to another level. The grace period is over. More and more health plans, and it could even be a state board. If a complaint is ever filed against you by a state board, they're going to want to see your documentation. If there's ever a malpractice case, they're going to want to see what diagnosis codes you came up with and how did you come up with it. You see, years ago, if a patient came into my practice and they said, Dr. Kotler, I have back pain and pain radiating down my leg, I just diagnosed sciatica. I didn't do any ortho or neuro tests. It's pretty simple, right? It was straightforward. Well, those days are over. If the patient has sciatica, you have to do some ortho-neuro tests. So the point here with sacroiliac joint, my recommendation is if you're going to diagnose a sacroiliac joint problem, then do Yeomans, do Ganslins, do some ortho-neuro tests to help substantiate the code that you bill. Very important nowadays because I see more and more health plans denying claims because the diagnosis was not supported in the notes. And another, common, this is a page out of a book that I wrote on how to come up with these ortho-neuro findings. So for example, cervical brachial syndrome, M53.1, also another very common diagnosis used in chiropractic. So if you're ever questioned, if you're ever, being hassled, so to speak, by someone asking, how did you come up with cervical brachial syndrome? What did you do? I would recommend you do right here at the bottom of the screen. It says Wright's, Atson's. You checked reflexes. You looked for myotomal weakness. There was forward head carriage. The patient had pain and numbness radiating down an arm. So, these, and then there's also these quick guides that I've come up with, which is in a book that I've written, which I'll tell you about a little bit later. Now, let me give you a couple of clinical examples. Here, Mrs. Thomas enters with a headache on the right side for 2 days. The headache is always on one side. Sometimes she cannot think clearly. No aura symptoms. Massage helps. She also has neck pain. The neck pain scale is 7 out of 10, 65% of the day. The patient brought in x-rays, and the x-rays show disc degeneration at C5, C6. You do an exam. You find spasm in the cervical region and subluxation. So here we go. G43.009 is migraine headache without aura, non-intractable. Make sure you know the difference between with aura, without aura, intractable, not intractable. Those are the choices you're going to get in the G codes for headache. And then we have neck pain, cervical subluxation, spasm, and the disc degeneration. Next, Mr. Jones enters the office for the first time with complaints from an auto accident. The collision was traumatic. He was a passenger in the front seat and was severely jolted by the crash. He felt immediate low back pain on both sides and right hip pain. He also hit his knee against the dashboard. And then we have spasm and restriction and subluxations. We also looked at his knee. It's swollen. It was red. He's got a contusion on his knee. So here are our diagnosis codes. We're starting off with lumbar sprain, not strain. Strain is a short-term treatment diagnosis code. Strain relates to muscles. They heal quickly. Sprain relates to ligaments. That could take months and months to heal. And then we also have back pain and spasm and the traumatic subluxation codes, and then the right hip pain, and then the swelling of the knee, M25.461, and then the contusion. S codes, you see S codes here. S codes mean that there's trauma. There's some sort of injury related to the diagnosis, and you also have to use a 7th-digit extender. Next, Mrs. Miller enters the office with low back pain and pain radiating down the posterolateral aspect of her leg and foot. She has some tingling in her calf. She has a history of fibromyalgia. So here's where, okay, we have a patient radiating with pain radiating down the leg. So straight leg raise, yeah. Do some tests that substantiate your diagnosis of sciatica. Diminished lower extremity reflexes, spasm, subluxation, right SI joint, and right hip pain. So here we go, M54.41. I call that a combo code. That's low back pain with sciatica, right side. We have spasm, lumbar subluxation, and then we have the pelvic subluxation and the lower extremity, right hip subluxation, and then we have the numbness and then fibromyalgia. Let me give you a couple of Medicare examples here. Mrs. Smith presents with neck pain and stiffness. We do an exam. We find tenderness in the mid-cervical paravertebral muscles, subluxation C5, C6, hypertonicity in the cervical extensor muscles, painful and restricted range of motion. So there's cervical subluxation, there's the disc degeneration, the neck pain, the spasm. So that's 4-0. 4-1 gets a little bit more complicated. Anytime when I'm doing a review, when I'm looking at a client's notes, and many doctors send me notes because they go, Marty, take a look at my notes, be brutally honest with me, tell me what you think. These are the offices that I find to be very up on running a good business, because there's a business that needs protection. Just like for your house, you have homeowners insurance, right? You have insurance. You know, I look at getting someone to look at your data. Now, it doesn't have to be target coding. If you don't want to use me, you don't want to use my company, that's fine. Use someone else. Get somebody to take a look at your claims. One of the first things I look at when one of my clients asks me to look at claims when they're billing 98941 is, what did the patient say? So in this case, the patient says low back pain, mid back pain, neck pain, exam, tenderness, subluxation, hypertonicity, restricted and painful lumbar range of motion. You see, that's the part exam for Medicare. X-rays reveal C5, C6, L3 to L5 disc degeneration. So here we go. We have for 98941, you want 3 subluxations and 3 secondaries. Alrighty, so just a few closing comments. Please check with all the carriers you bill prior to submitting claims based on the information in this presentation to ensure that it is compliant. Target coding does not guarantee that this information will guarantee payment from any insurance plan or patient. We're not responsible for any rules or laws that may change following this presentation. Do your best to stay on top of changes by attending seminars, webinars, and joining your national and state professional associations. Here's our contact information: email info@targetcoding.com, website targetcoding.com, telephone number 1-800-270-7044, fax is 1-844-831-2347. Now, before we get to questions, let me tell you, here's the book that I was referring to. This is an excellent book. I recommend every chiropractor have this in his or her library. This is the book on the best chiropractic ICD-10 and CPT codes to improve reimbursement. I like the little tagline there. It says, learning how to bill and code isn't expensive, but neglecting it and defending it is. So I mentioned these have a whole bunch of diagnosis codes, and then the ortho, neuro, and chiro tests that help support it. And then we have these cheat sheets or quick guides on what are the codes that pay the most visits. We have a section on frequently asked questions like, what's the difference between myofasciitis, myofascial pain, and myositis? What's the difference between radiculitis, radiculopathy, and myelopathy? What's the difference between, spasm and contracture? A whole bunch of very, very common questions. And then we have these sheets in here that show you how to pair. Like I mentioned earlier, you want to pair, like you pair red wine with your steak. I show you how to pair your procedure codes to your diagnosis codes. We do seminars and webinars throughout the country. We have a whole bunch coming up. Check our website. We also do a lot of HIPAA compliance. HIPAA compliance is becoming more important now than ever before. Why? I'm not telling you that to scare you. It's just pick up any chiropractic journal, newsletter, magazine. Nowadays, HIPAA is mentioned in every one. The HIPAA police are out, and unfortunately, they're coming after private small practices now. So that's why we offer now HIPAA and OIG compliance. HIPAA compliance program We have a very comprehensive one. It's not one where we just give you a bunch of forms and you do it on your own. It's a concierge premier type service where we do a lot of the work for you. We do a comprehensive security risk analysis with detailed report. We provide a cloud-based storage portal. So all your HIPAA policies and procedures are available from any internet website or any, you could have access to this anywhere in the world. You could also download all of them, save them on your hard drive, and print them out if you would like. There's training videos for staff members and certificates of completion and business associate tracking. So those are just a few of the things that we offer here at Target Coding. We also have memberships. And again, here's our contact information. I hope everybody learned a lot. Thank you for attending.